discuss various topics related to health. We provide scientific information without any commercial influence. I am Dr. Dhiren Ganjwala, and I am going to be the host of this session. As many non-medicos people are watching this webinar over and above the orthopedic surgeons, we will interact in very easy to understand manner without any medical jargon. In the last webinar, we discussed about various food components like wheat, rice, millets, fruits, juices, vegetables, etc. But we could not discuss many other components of our diet. We received so many questions from our viewer that we decided to have the part 2 of the webinar. If you have not listened to part 1, I strongly recommend you that please listen to that webinar also, and it is as useful as this webinar. Today we are going to discuss more points, more tips for control of blood sugar. Our focus is mainly on those who have diabetes or those who are in pre-diabetic stage. But let me tell you that it is going to be useful to everyone, because now we have enough data evidence which says that if we try to reduce the variability in our blood glucose, then definitely it helps us in a long run. We have 3 experts with us. They are not only great clinicians, but they are also great academicians also. So let me give a brief introduction about that. Professor Sunil Mishra is an endocrinologist and diabetologist practicing at a very premier institute, that's a Medanta hospital in Gurgaon. Because he is from Delhi and is stuck in traffic, so he is going to join very soon. So he has conveyed his apology for that. He did his DM endocrinology from AIIMS, New Delhi. The second expert is Dr. Urman Dhruv. He is a physician and internal medicine expert at HCG Medical Hospital in Ahmedabad. He runs a series of YouTube programs about the myths about diabetes. He is a well-read person and up-to-date about the recent advances in medicine. He is also very active in state and national conference, particularly related to diabetes and the internal medicine. The third speaker, the third expert is Dr. Malhar Ganla. He practices in Pune. He is a co-founder of 2 organizations, Freedom for Obesity, and he is also a chief information officer for Freedom from Diabetes. He has been invited to speak at TED Talk twice, which is a very rare achievement. And I really congratulate him for that great achievement. He also is a great fitness enthusiastic. And if you look at his body, you can say that he is a really fitness freak. Before we start our discussion, let me give a disclaimer information that this webinar is basically to provide information to you. It's basically for the purpose of education. Please consult your doctor, your physician, before you apply this information to your disease or the control of diabetes. If you have any question, you can send me the question by WhatsApp or a text message on a number. Please write down that number. It's 97129 25600. I repeat, 97129 25600. So with that, let's start the discussion. And the first topic, which is like a lot of people ask about the question, and that's about the diabetic patient. They are restricted about the sweets. They are not, or the doctor says that don't eat sweets. So for them, there is a alternative. The first alternative is to use sugar substitute. Before we go on for the discussion, let me give you a brief understanding about the sugar. What we call a sugar or the table sugar is made up of 2 components. The first is glucose and the second component is fructose. Now, this fructose, in a table sugar, both are 50-50. The fructose is 50% and the remaining half is by glucose. Now, when we measure the blood glucose by glucometer, by the blood test, or by the continuous glucose monitoring, we are measuring the glucose in the blood or in the interstitial fluid. but we are not measuring the fructose. Now, we know that this fructose is a major problem for diabetes, for obesity, and for metabolic syndrome. So it's a hidden enemy which is not reflected by any mean in the blood test, but it goes on carrying out damage to the body. So naturally, it's very important that we restrict our sugar intake. Now, one of the alternative, which, as I said, is to use a substance which give sweetness, but it does not have glucose or fructose in it. So I would like to ask first question to Dr. Urman Bhai. What is your preference for this sugar substitute? There is a wide range of substance available. So what do you say, and what is your preferred sugar substitute?
So there are two sorts of sugar substitutes. One is non-caloric substitute, and the other one is very low caloric substitutes. FDA has already approved 10 non-sugar substitutes, or non-sugar sweeteners as we call them, NSS, which have been found to be safe till now. You'll be listening a lot from 15th May 2023 about WHO's recommendation, which we'll be talking about little later. But first, efficacy of sugar substitute and which one to select. So as far as the efficacy is concerned, almost all non-caloric sugar sweeteners are practically the same as far as efficacy is concerned. It would more or less depend upon your choice and your financial budget. Why financial budget? Because there are several sugar substitutes like saccharin, which when used in a hot cooking area or in a hot cooking substances, it would have some bitter taste. It's very, very sweet, but it would give you bitter taste when it is heated along with the food. So you may not like it when you use it in heated substances. There are some substances like sucralose, which is actually created from sugarcane only, and which is practically 1,000 times sweeter than sugar itself. And when used with heated substances, they don't lose their sweetness. In fact, there are many patients who like sucralose more than even sugar, and they are acquainted with it. So as far as the taste is concerned, sucralose probably scores over rest of them. There are like Advantame or Neotame, which are not very easily available in India. Saccharin is available as sweet and low. We generally don't take trade names here, but just for the sake of those who are not medicos, for them these are the trade names that I'll be writing. Sucralose is available as Splenda. Commonest one that we use in India is sugar-free. That is a brand name. There are other brand names also. And there are three sorts of sugar-free that are available. The sugar-free routine, that is known as saccharin. The sugar-free gold, that is known as sucralose. And then comes sugar-free green, which is actually stevia. Now, what is this stevia? Stevia is actually created from plants. And there are many of our patients who have now grown these plants in India in their gardens also. You can do it. But actually, it's a plant that was available or that was grown or cultivated in Europe. So it's basically a plant-based medicine or plant-based product. I would not call it even medicine, plant-based product. And so probably it is safest of all. There are other group of drugs which are low-caloric substances like sugar-based alcohol, which gives around 2.4 kilocalories per gram, like erythritol, sorbitol, and xylitol. And they are being utilized in multiple drugs also, especially when the drug is required for diabetes, which should be sugar-free. So coming to your question, which one to choose? If I'm given a choice, obviously I would go with stevia, but it is very, very costly. And there are no additional benefit except for the fact that it is coming from the plant. So the second choice would come as sucralose, which is absolutely sweet, can be used in, as I told you, with heated substances. The one that I would like to avoid would be probably the saccharin, not because it has been blamed a lot, but because it loses its taste or becomes bitter in hot substances. Saccharin has been blamed a lot, but still it has survived last 50 years. When it comes to non-sugar sweeteners, it's going to be a fight or a competition between evidence-based medicine versus experience-based medicine, which we'll see later on. So, in short, sucralose, to be very specific, should be one of the best sugar substitutes that is available at present.
Okay, and then one question about the tea or a coffee. Like if we want to add sugar substitute in a hot tea and coffee, which one is preferred one? Because as you said, saccharin has a bitter taste when it's heated. So naturally it is out of question. But the other two are okay, stevia and...
Absolutely. Stevia and sucralose both are okay. Both give excellent taste. And most of the patients, as I say, they forget to use sugar once they use this. Both of them are 0 caloric. So you can add it to sugar, add it to tea or coffee. But remember, taking tea or coffee with these sugar-free substances does not mean that you are having a 0 calorie drink. Because if you are adding milk to it, it is all one and the same. So always remember, it is the milk that gives you calories, even if you use 0 caloric sweeteners. So if at all you want to be away from the calories, it should be a black tea or black coffee with sugar sweeteners.
Okay, and then there is one new sugar substitute which has become very popular, particularly those who are coming from USA, and that's a monk fruit. So what is that and how safe or effective it is? Let's talk about the effect first, and then we will go to the safety part.
Right. So monk fruit has been recently approved in 2019 by FDA, and it is actually basically coming from China and Asia to US, and then now taking a longer turn, it is coming back to India through USA. It is still not available commercially in India. It is basically again a plant substance and with excellent taste, but once again, it is in heated substances, it becomes little bitter, so everybody may not like it, but it is absolutely safe because it's a plant product.
Okay, so you talked about the efficacy part. The more controversial thing which we time and again see in some or the other WhatsApp or in the newspaper about the side effect part. So what are the side effects likely, or they are just too much of what hype. I say, like the
hype.
Yeah, hype which has been created in the media. So what about the safety part?
So again, it is a huge war between experience-based medicine and evidence-based medicine. Experience-based medicine say that we have been using these substances for years together. FDA has approved their efficacy and safety for years together, probably decades, we can say now, because I have been using it since 87 in our patients when I started my practice. So it is nearly 37 years and probably more since these substances are available. But there are certain things that came off recently. So we'll divide the use of these substances in patients having diabetes and patients not having diabetes. So when it comes to patients having diabetes, practically I would say there are no side effects. Saccharin was known to cause carcinogenicity, but that has been completely ruled out in multiple bigger trials, and our clinical experience also says the same thing. They have been blamed to alter the gut motility and gut bacteria, but again, it has never been proven in a single trial. Then why there are problems? So, the drug, these substances are being used in patients who are not having diabetes with an idea of reducing weight. And then came a couple of trials in 2015, 2018, 2019. And all these trials came out strongly that they affect the appetite and then they affect the neurohumoral system, which leads to increased appetite later on, a rebound increased appetite. And number two, it affects lots of hormones in the brain, and that leads ultimately to secretion of less of serotonin, less of dopamine, and ultimately it affects the heart. So all the trials recently that have come out, they suggest that rather than reducing the weight, they may increase the weight. The increase in weight may not be very evident, but one thing is certain, they do not reduce the weight because overall, feeling very safe, people start taking lots of calories and simultaneously there is increase in the appetite. So WHO on 15th May 2023 came out with a very challenging guidelines saying that non-sugar substitutes should not be used in patients who are not having diabetes and who are using it to reduce the weight. There were few reasons also, because multiple trials suggested that when non-sugar sweeteners were used in patients who are not having diabetes, they actually increase weight, they increase triglyceride, and in few studies, they revealed increased cardiovascular mortality. So the verdict is still not out, jury is still not out in patients having do not have diabetes, but WHO says that it is safer not to use these substances if you do not have diabetes, especially for reducing the weight, and instead you should use the sweet substances from the food, like you can use dates, like you can use carrots, or you can use some other substances which is coming from the food, rather than using these substances until they are cleared off. And therefore, the safety says that this sort of substances should not be utilized in patients who are not having diabetes. And if you are seriously trying to reduce the weight, they are not going to be useful. Another important thing, all non-sugar substitutes are contraindicated in pediatric age group below 2 and strictly contraindicated during pregnancy. So a female who is in a reproductive age group, especially type 1 diabetic, who would be in that age group, you should be very careful. If they miss the periods, become pregnant, the substances should be immediately stopped. Otherwise, in patients who are having diabetes, the number of tablets or number of milligrams that we are using is far more than the dose that can cause adverse effect. So WHO says that you can safely use 18 tablets of sucralose per day or around 16 tablets of saccharin per day, but we generally in our practice keep it to 10 tablets per day. And we know that most of our patients are even wiser. If we allow them 10, they only use 6 or 8. So whatever our patients are using, it should be less than 10 if you are having diabetes. Otherwise, it is safer not to use these substances. However, the sugar alcohols like xylitol or sorbitol can be safely used even in medicines or even in as the people who want to reduce weight because they are having low caloric substances, and this ban or this indication does not apply to them. Remember, WHO has still not suggested to take off these substances from wherever they are added in minute quantity, like toothpaste or any other food substances where they are added in very minor quantity. So they are certainly not carcinogenic, but the only indication that people were using was to reduce weight. It is not working.
Okay, good thing. And what you mentioned is also observed in USA. See, the Diet Coke came with the idea that the Coke has a high amount of sugar and that is responsible for obesity. And so they came out with Diet Coke. But that introduction of Diet Coke does not have any effect or did not have any effect on the obesity. So what you said is very true, that it's a sweet taste which make us or force us to have more eating rather than the calories part. So I fully agree with you. Now, you mentioned about something, and I would like to ask the same question to Dr. Malhar. That is about the recently, like say in Gujarat, we had a Diwali, and during Diwali time, the people, they gift sweets to each other. And now we had a trend, and that trend says that this has used sugar-free sweets or something. They have used something like dates or some other component for making it sweet. So there is no sugar added to that. There is no honey, but it has some natural sugar in it. So what do you think about the using that in a diabetic person?
Thank you, sir. I think Dhruv sir has very eloquently and elaborately, covered so technically. It's wonderful to hear such details. But to tell you the truth, I have found that, sir, the minute we take away the actual sweetness of sugar from food, the amount of volume that people start eating to reach that level of dopamine, the bliss point as it's called in the sugar industry, which is the amount of sugar required to secrete that much dopamine so a person gets that feedback and stops eating. It has to be, in a way, they have to replicate. And I have found that if it's a regular, if it contains jaggery or regular sugars, which are, even if it's a fruit-based sugar, even if it's a date, they'll stop at 1 or 2 kaju katli pieces, or they'll stop at one of those laddus. The minute you artificial sweetener, I find they eat 3 and 4 to get that same effect. So the carbohydrate collaterally, we may say saving the, missing for the trees. You have saved 5 grams of sugar, but then the actual carb intake has gone in almost 30-40 grams. So it's a bit 22 situation, if you ask me. And I personally tell patients ki only sugar can do, only chocolate can do what chocolate can do. We can keep replacing substances that can chemically reproduce the taste, but they will not reproduce the dopamine in that same dosage. So I find that people, because stevia as a drop, we are finally adding it to something, and that dilute it can, and the diabetic for the sweeter taste, it is there. There is already, I call it a sweetness resistance. There is a resistance tolerating small doses of sugar. They constantly, intake. So I think, it's a, they have to learn to eat smaller doses, and to me, sugar substitute it, but to be, I've also tried all of them. They come nowhere close to what even quarter teaspoon of sugar in your tea would do. So, while they initially once trying to bring
Dr.
one's
Malhar,
A1C
your
down.
voice is breaking, so probably there is some issue with Wi-Fi.
Is it better now?
Yes, perfect.
This is the fan. Actually, when I found that, teaching people to eat the right quantity of sugar in the initial phases of sugar correction, when they are, HbA1cs are high, initially all these things do help. But over a longer period of time, I have found that teaching them to have the right dosage, even if it's sugar, raw sugar, is, and jaggery, it induces the satiety much faster than substitutes. This is my personal opinion. Again, from, like sir called it, experiential medicine. It's very great, when we say evidence-based, but finally the patient comes and tells you, sir, maja nahi aaya, kha liya par maza, wo meethe ka maza nahi aaya.
Or the other reason could be like when you are using or using the sugar substitute, you have a feeling that the guilt part is taken care of with that, and that's why probably you may be eating more. That could be the reason.
It is there, and it's like non-alcoholic beer. Patients
Yeah,
tell us that
exactly.
we
So you
have
consider-
non-alcoholic beer, but it didn't have the desired effect. So it's the same thing. It's finally it is a placebo, no, to some extent, from a actual dopamine induction tongue receptor perspective. There is a placebo going on there. So all I'm saying is, I prefer going down that, instead of drawing a line and saying sugar is bad for you and sugar substitutes are good for you, you need to learn to balance both, So I think eventually over a period of time.
Okay, fine. So we tackled the important point about the sugar or the sweet taste. So probably it's a sweet taste which is we all crave for, and one or the other way we have to support it, or we have to supply it to our body or to our mind. Now we are moving to the another component of our food, of our diet, and that's about the protein. And protein is a very important component of our diet. And for that, I would like to ask Dr. Sunil Mishra is with us. So, sir, welcome. And the question is for you. And that question is about the three things which is very important, because for any person, adequate protein intake is very important. And according to me, the cheese, paneer, and the tofu, they are really a good source for everyone, vegetarian and non-vegetarian. So what do you think about using these substance, particularly the component of our diet or the food for the protein part? How safe they are for with a person with diabetes?
Right. So, good question, because the protein content in our kind of the diet, especially the Indian diet, is low, and most of the people, those who even take non-vegetarian diet, uh, they are deficient in the protein intake. So people then in our country, the most people are vegetarian, and for vegetarian, the reliable source of protein is again limited. So in that sense, obviously, the milk-based protein does take a big role, and I feel in that sense the paneer might serve a better purpose rather than the tofu and the cheese. Now, I have some little explanation for that. Now, how do we eat cheese? So most of the people eat cheese in a different manner, right? So it will be either be baked or either will be taken by the refined carbohydrate kind of the food, and so the nutritive value and what we are taking it for actually is lost. Whereas the paneer can be taken in a much different manner. It can be taken as a salad. It can be taken directly also, right? And it gives you a lot of and ease of having protein. Paneer is much easy. Now, tofu, the availability becomes a little challenge to most of the places. So for me, if you ask me, so paneer is the easiest source, and for a day-to-day thing, we should not complicate. See, generation been surviving because of the healthy diet. Only thing is that they have not complicated the diet that much. They have kept the things simple. Now we are currently facing the challenge of the lifestyle disease because we have complicated the diet.
Okay, so according to you, eating cheese is not an issue, but the component for which add like something like a pizza. So the base of the pizza is really a problem. Or if
Correct.
you say burger, in that case, basically the bread is a problem, not the
bread
cheese.
is a problem.
Yeah.
And also if you look at the calorie value, because the fat proportion of in these three things, which the option you have given, and these are a very common things people can have. Now, paneer, tofu, and cheese. So the calorie value of these things, I think the cheese will go on the top. So for the same thing, the cheese will give people more calories. So that in long term, immediately, if someone will ask, I have checked my sugar didn't went high after having cheese, and that's what many a time people will say. I ate sweet, but my sugar didn't high. So is it okay? Short term, it may not increase the sugar that much, but in long term, obviously, those excess calorie will be deposited, will create a weight gain. And as we know, the 3 kg of the weight gain offset 1% benefit in by reduction of the HbA1c. That's a very well known fact. So that 3 kg weight gain will offset the benefit of 1% HbA1c reduction.
Okay, so it does not have an effect on the blood glucose, but yes, by having a excess calorie, it leads to weight gain, and in a long run, that may adversely affect diabetes.
That will be counterproductive, and that will not only the diabetes, but also the metabolic problem that are associated with the diabetes, like fatty liver, cardiovascular disease, hypertension, increased adiposity, obviously increasing the risk of the sleep apnea and all. So those problems will be definitely surface in long.
With that.
Yes.
Good. So the second source of protein, particularly those who are consuming eggs. So yes, eggs is really a good source of protein. But recently, a controversy has been added, and that is about it has a negative effect on the gut microbiome. And because of that, one of my friend who recently visited USA, he was advised by a nutrition expert over there that eggs are not good for a person with diabetes. Urman bhai, what do you think about that? And how far that is true? Yeah, please unmute yourself.
Well, for that we need to understand what the egg contains. Egg, as we all know, as egg white and egg yolk. The egg yolk portion contains around 4.5 grams of fat, 1.6 grams of saturated fatty acids, 184 milligrams of cholesterol, around 1 gram of carbohydrate, and 2.5 grams of protein. While the white of the egg contains around 4.5 grams of protein, and a protein which is formed of 9 amino acids, which our body cannot generate, and therefore probably one of the best proteins that is available through the diet. So eggs should have been easily acceptable and should not have any problems. But the reason why egg was always considered to be a non-favorite item was because of the cholesterol content it had. But once the ADA removed the dietary cholesterol levels, because we realized that it is not dietary cholesterol that is important for dyslipidemia or for hyperlipidemia in the body, it's the liver that creates the cholesterol from that. So once those dietary cholesterol levels were removed, the egg became safer alternative for proteins. Then still there were problems. What were those problems? In the studies which were carried out, epidemiological studies, which were very huge studies, nurses' health studies or physician studies, all those studies suggested that when the person was taking more than one egg per day, either a physician or a nursing staff, they found out that there was additional cardiovascular mortality. And that's why, once again, the egg went out of the favorite area of the nutritionist. Once again, few more studies came which suggested that eggs are actually having only 80 calories, and when baked or boiled, they are very useful. So things went again very well. Now, we can cut it short and find out what is the ultimate answer. So the ultimate answer is studies carried out, Diab egg study, and then 3 more studies, a couple by Chinese people. They suggested that when the eggs were used in place of breakfast with equi-calorie content. Remember this word, which our colleagues also just now told you, that if it is equi-calorie content, eggs are acceptable as a food for type 2 diabetes because they actually help to provide a better protein. But when the same eggs were given to people having no history of diabetes, multiple studies have suggested they actually increase the prevalence and incidence of diabetes in them. So the jury for the time being is out, and it says that if you are having diabetes, you can take eggs at the most 12 eggs per week, which means 2 eggs per day, not more than that. Lower the better. So 6 to 12 eggs per day for a patient having diabetes in place of or by reducing some carbohydrate from his diet would help control his sugars, probably reduce his weight, and probably help in cardiovascular outcome. But the people who are not having diabetes, in them, eggs cause increased incidence of development of diabetes, and therefore they should keep their egg intake to not more than 4 per week. So that is at present the recommendations that are available. Nobody has at present enough reasons to find out why. There are multiple hypotheses, but not enough reasons to find out why the increased incidence of diabetes or development of diabetes is seen those who are not having diabetes and are taking more than 12 eggs per day. So those who are having diabetes can replace your breakfast, especially carbohydrate, with eggs, always good. But those who are not having diabetes, don't indulge into taking lots of eggs.
Again, so really you have created one, or like explained us about one more controversy about the diet. And I don't know that like we call it this as a science, but every few years we have one or the other such controversial declaration by the association or by the study. And that is really alarming that a person without diabetes should not consume more than 4 eggs in a week, which is really something shocking and surprising also. So, fine.
So couple of trials couple of trials about eggs, non-sugar sweeteners, and multiple other substances of late have probably suggested that patients who are not having diabetes have a physiology which is probably spoiled by these substances, which are acceptable once the physiology becomes pathology in diabetes.
Okay, good. So with that, we move on to the another component of our diet, and that is about oil. And Dr. Malhar, I would like to ask you about your views about oil.
So,
I'm
of course,
sure that it is equally controversial like the eggs
protein.
or the protein or
Yeah, I'll just quickly add to that protein part for diabetics, just one line, because the trend now is to 1 gram per kg is what they hope to have. But since we are the lightweight diabetics of the world, the 50, 55 kg, 60 kg diabetics, so these guys, if that 50, 55 grams is very inadequate, they keep losing muscle at that range because they undereat carbohydrate all the time. And we find that if we increase the protein, of course, the creatinine starts rising. So it's a catch-22. But I found a lot of patients settling down when they take supplementation because the cost of protein per unit carbohydrate that they have to have in the natural world is very high. So when they add an isolated protein molecule to their diet, which could also be an egg, because an egg finally is an there's no collateral carbohydrate, but in the protein powders of the world, I have found fantastic results with regaining muscle mass. So, especially chest muscles, the hamstrings, they get a lot of postural correction when they put back at least, if not 1.5 grams of protein per kg of body weight. So again, that's from an Indian perspective, I'm saying. Secondly, about the oils, again, we are a very oil avoiding nation when it comes to, straight oil, like olive oil on salads, we won't have, but we won't mind a deep fried samosa. So we are very, if we can't see the oil, we'll have it. If we can see the oil, we won't have it. We love frying carbohydrate in oil. So we do recommend cold pressed oils and we have found very good results. But again, we keep the oil low because we find immediate spikes in cholesterol when it crosses 1 gram, 1 ml per kg. So immediate triglyceride levels start rising and the fatty liver seems to get worse. Again, as sir very rightly put, if it's an equicaloric diet, if it's equal to your metabolic rate, it's all fine. The minute you start adding it on top of your already higher calorie diet, it starts creating problems. So I found 1 gram to 1.5 grams / ml per kg of fat, of oil, basically pure oil, to be fine. So we do tell them to add it, especially for the weight gain category, on their salads and everything, and we have found no problems. But deep frying carbohydrate, I mean, will always be frowned upon in the Indian context, So that's my personal view,
Okay, and what about the one particular oil is better for blood sugar or something like that?
We just prefer cold pressed. It should not be heated or excessively processed. It's just cold pressed, and it's excreted or isolated from that particular source, and it's fine. Like, we don't get it too much. Even the coconut oils are fine. They're all good. But again, people prefer the smell of an oil. They don't like certain oils because of the tendency to smell. So we haven't found too much difference in results. Because I've got north to south and east to west. We find so much variance in the choice, So finally, we just tell them any cold press native to your region is fine. That's what we find. Oh.
Okay, fine. So once we completed the part of the diet, now we go to another important point, and I have really found conflicting views, and that is about the number of meals. A lot of patients, they come out with a question that my doctor has suggested to eat frequent meals at every 2 hours. While some doctor says that go for an intermittent fasting and try to reduce the hours in which, or the window in which you are eating. So, Dr. Mishra, what are your views about the number of meals first? That's the most controversial point.
Okay. So I think the problem is that de-learning is very difficult, right? And the learning is again a difficult. I'm not saying the learning is not that difficult, but de-learning is again difficult. So most of the people being told that if you are diabetic, keep eating every 2 hours. And now, what is the healthy diet? So healthy diet to me is the diet food that is cooked at home from raw, the substances we use in our kitchen is the healthy diet. Now, to presume that if you have to eat every 2 hours, what you will anyone will cook you for every 2 hours? Or will you be waiting at home to eat every 2 hours? Not possible. Most of the people are working, right? So, and especially working people are away from home 10, 12, 14 hours, right? And obviously, to have that number of meals is really challenging. And also it depends upon the societal behavior. Now, I used to work right now in Dehradun, but I used to work at for last 12, 13 years at Delhi NCR and Haryana, the state where people have habit of taking 2 meals only. So they take breakfast come lunch around 11 o'clock and one evening meal. So that's kind of the supper or dinner, you can say. And if you go to the rural Haryana, people take dahi, people take milk, good amount of the milk, people take ghee, they eat 2 meals, they are 80, 90-year-old and straight, no excess fat, living healthy, right? Even the 80, 90-year-old will look like as young as 50, 60, right? So now you tell them you eat every 2 hourly after becoming a diabetic, it is becoming difficult. And who will cook meal for them? And that kind of the eating behavior is not beneficial. Now, what the diet is that the kind of the meal pattern people should learn at home. If they are having 2 meals, it is better to stick to 2 meals. In between, if people want, they can have healthy snacks like fruits, nuts, seeds, and so many things are available nowadays. People who can afford, people who cannot afford, the seasonal things are always there, right? The only thing is that we have to see what is healthy, what is unhealthy. Second part is that the weight is important. Now, before telling people, especially type 2 diabetic, people who are on medication, those who are not causing hypoglycemia, like non-sulfonylurea medication, metformin, DPP-4 inhibitor, SGLT2 inhibitor, or the GLP-based therapy, and when weight loss is desired, I don't think excess calorie intake is should be advised. So they should be advised to restrict the calories. The micronutrient component should also be taken into account, right? And if I see people, especially people who are migrant, shifted from Eastern UP, Bihar, or even from the Bengal, those who come to work in Delhi. So most of their diet is only carbohydrate. So they take n number of chapatis, right? Or they take a huge amount of the rice. And if you tell them you are diabetic, you have to eat more. So obviously they will eat those substances only. So the education regarding the diet is important. Nowadays, no one will get harmed or come across any disease by eating less, people who can afford. Most people are getting mortality and morbidity because of eating more. And I tell people upfront that, look, who is eating whom? You are eating food or food is eating you. So you have to decide. So eat less, eat healthy, eat on time. Nutritive value, the caloric value should be taken into account. And of course, if you are a person with diabetes and where your medication can cause hypoglycemia, then you have to take into account that the bridging snack should be placed in a manner that you should avoid hypoglycemia, should be kept simple for people. And most of the time, I tell my dietitian or educator not to change the behavior. Like if I try to change the behavior of a person who is coming from Haryana, where meal is cooked only 2 times, who will cook meal 3 times or 4 times for him? So I have to give the option of easy option for them also.
Good. Yeah. Thank you. Then the next question I would like to discuss is about the changing the sequence of meal. And in that, the first thing is about salads. Salads are basically having a lot of fibers and very little calories. So there is one WhatsApp video which is moving by the author of a book, Glucose Revolution. And in book, Jessica recommended that if you eat a salad first, she explained that it would coat your stomach and that would reduce the absorbability of the food which you eat next. So Dr. Malhar, what are your views about that? Is it really a practical solution or suggestions, or it does not have any practical usability?
I think these are all great tips to sort of occupy the mind, just to give them something to do. At the end of the day, people need 1,500 to 2,000 calories a day. They are going to exercise. They are going to do certain activities, age appropriate. So there will be a requirement of calories. Now, salad is finally either calorie negative or it is calorie zero. So it has no net contribution to energy levels. So the balance will come from some stored fat or glycogen or somewhere. So there will be a deficit, there will be muscle loss eventually. And I find all this leads to calorie dumping at some point. Second day, third day, when there is a lot of sugar deprivation, glycogen level starts going down in the liver and in the muscle. The patient sits down and eats 1,000-calorie meal somewhere. So this rebound dumping which occurs, with excessive low calorie foods, I think the temptation in diabetics is to undereat severely and overexercise. So that tendency to do too much cardio, which anyway reduces glycogen, undereat carbohydrates, which again suppresses glycogen, creates a permanent hunger status after some time. And it's sort of like a survival mechanism which kicks in. And then they're always chasing calories. And then to keep the blood sugar up, they keep eating sweet, high glycemic foods. So this vicious cycle, I think it's always better to eat the complex carb, which is the standard, but limit the glycemic load. 50, 60 grams, 2 rotis with dal, with rice, whatever. It should stop at below the GTD test, 75 grams. You've got to learn to eat to 1 or 1.5 serving of carbohydrate, get your 0.5 or 1 gram of protein and a little bit of the balanced, quintessential Indian balanced diet. I think anything else is going to be a short, like sir said, it is finally short term. You like these neutral diets, which we try and apply to the whole world. I think that generalization won't work. Finally, localization within their, native behavior, like sir said, it has to be, the right approach.
Okay. And then there is another tip which the same book has mentioned, and that's about the apple cider. So the author recommended that using small quantity, say 15 ml or 30 ml of apple cider before the meal, and that again reduces the glucose absorption, and that also reduces the glucose spike. So Urman bhai, what do you think about using that strategy for reducing the blood sugar level? The author does not say that you change your diet. It's just addition of 15 to 30 ml of apple cider before meal. That is what the author says. So what do you think about that suggestion?
So basically, there is very minimal controversy, at least in this answer, because apple cider vinegar, basically, vinegar itself means a sour wine. So apple cider vinegar basically is nothing but acetic acid or acetic acid as we call it. And it is nothing but a very, very nice probiotic where you have fermented apple with the help of fungi or yeast and created probiotic where the upper layer is mother and that contains lots of probiotic. All studies have shown that this ACV, that is apple vinegar, generally reduces weight by 1 to 2 kilograms. It has no direct effect on blood sugars, but it reduces weight by 1 to 2 kilograms, and thereby it produces improved insulin sensitivity and probably moderate or not even moderate, but minor reduction in the glycemia. So that is probably all the studies are saying. But if you open the internet, it would say that apple cider vinegar, it reduces blood pressure, it reduces cancer, it reduces so and so. And many doctors are also tempted by this. So do not please believe on those internet versions of the advantages. But As far as apple cider vinegar is concerned, that may be used. That is one of the best probiotics. Probiotics have already been used now in type 1 diabetes, and probably they would be useful in type 2 diabetes also. So, yes, one can use it jolly well with some expectation of reducing the weight. But please, if you are using apple cider vinegar, don't stop going to your gym, because that is going to produce more weight loss rather than anything else.
So it's not a substitution of the good measures or the proven measures. It's just an
It's a
addition
very
of
small complementary help.
complementary. Yeah, exactly. So that's very important message. Now we come to some other options of the blood glucose management other than diet. And for that, we have a few things, that's exercise and the stress relief. So I would like to ask Dr. Mishra about what are your views about this stress management? Because we say that in the etiology of diabetes, that stress is one of the, or it plays a very important role. So naturally, on the same base, it says that the stress relieving or the stress management helps. So what do you suggest to your patient for that?
Okay. Now, you have very rightly said that the etiology of the diabetes, stress does play large part. Now, if you look at the etiology of the diabetes, today we are not only the insulin deficiency or insulin resistance, but it's the ominous octet. So that means what we know today, that there are 8 factors which result into the occurrence or development of the type 2 diabetes. Okay. And among the 8 factors, the brain is also one of the factor. So the neurotransmitter from the brain, which plays its part through indirectly to the pancreas by creating more insulin resistance, result into the occurrence of the type 2 diabetes. But the only challenge is that how to address that. Like we know for very long, probably more than 100 years, that there are hormones secreted from the intestine which modulate the glucose control. But only very recently, after 2005, we have a molecule in form of the GLP-1 receptor. And today, how these GLP molecules are changing the course of the diabetes treatment and obesity, everybody is aware about, right? So, but for the brain, we have very little to offer for, because we know very little about those neurotransmitters which create that. But it is well-known fact that people who are stressed, and especially the depression and stress, result into the occurrence of the diabetes. Now, some sort of the negativity will be in the mind of the people with the diabetes. I'm not denying that, because if anyone comes across a chronic disease which people have to bear for lifelong, as some sort of the low mood is known fact. But if that goes beyond certain limit, so definitely it plays a part in the glycemic control and the diabetes management. If you look at the people glucose profile, there will be many people who will come with the fasting hyperglycemia. Now that they look at the fasting hyperglycemia, so 2-3 factors determine the fasting hyperglycemia. Number one is the people who have a habit of having a late meal or excess carbohydrate in the night. And then people who are stressed, those who sleep poorly in the night, the fasting hyperglycemia is a very common occurrence in them. Right. Similarly, people changing mood, obsessive compulsive behavior or OCD sometime. When the mood changes, their glycemic parameter does change. So I have had people in sometime they require insulin, and when their mood changes, their insulin requirement goes away, or their glucose level start fluctuating. So stress does play a part in occurrence, as well as the glycemic control, as well as the long-term good metabolic control of the people with the diabetes. Now, what we should do is that whenever we come across a person with the diabetes, we have to do some sort of the basic psychoanalysis, right? So psychoanalysis in terms of their understanding, who is going to take care of the diabetes, are they mentally sound, strong enough to handle the diabetes control in long run. And because most of the time people will just come to settle down the numbers like fasting NPP and HbA1c. But we need to see beyond what is causing those fasting PP, HbA1c. So we should not stick to number. We have to have some patience listening to the people, and any experienced doctor can easily judge how to handle the patient, right? So you have to do a little conversation beyond routine things about the number, what you do, what is your profession, do you sleep well, financially we should try to help them out in terms of how we can minimize the thing. So it is very easy to say. So suppose if I come across an obese individual with diabetes, so if you lose weight, your glucose control will become easy, you will get less complication in long run, your cost of life, quality of life, and longevity will further change. So those things should be discussed. Then now you go to the some extreme. So those things simple we can do, but there will be people who are really stressed, those people who are having a real depression, right? So they should definitely be advised to see the qualified psychiatrist, right, and to have the medication routinely and regularly, and do help them in following with the psychiatrist. Many times in ROPD, we have to refer patient to the psychiatrist to help them out, because people with the diabetes can have stress because of the diabetes, and they can have stress and diabetes together also, right? But take home message to people is that they should, now we are in an era where we have multiple different kind of medication. We know little more than what we know 10-year, 15-year regarding the diabetes. Obviously in next 20-30 year we will become more wiser about how to take care of the diabetes. I'm not saying that, but today we know better than what we used to know 10-15 years before, and we know how to change the natural history of the diabetes. Natural history means that is for any chronic illness, the crux is that how to tweak the natural history, means at what point of the time they are going to develop what kind of the complication, we can change them, we can alter the course, and they can live a normal healthy life as maximum as possible. So for that, I agree with you that stress management is definitely important, can be done by the counseling at our end, or if required, any psychiatrist or counselor help or drug treatment whenever required should definitely be offered to them. That is going to help in many ways for the diabetes management.
Okay, thank you, sir. And now we are coming to the end of that. And so we will take two quick questions. And the first question I would like to ask Urman bhai about the exercise. How do you suggest your patients about exercise? Let's focus on the practical aspect. Like if you have a patient whose blood glucose or like HbA1c is remaining around 8, what will be your suggestions? You are mute. Urman bhai, you are mute.
I'll be very quick. First of all, contraindication to exercise. So before starting exercise, rule out diabetic nephropathy, rule out diabetic retinopathy, rule out established cardiovascular disease. Only then go for it. Ask the patient to have a very good pair of shoes, and then determine your aim of exercise. There could be 3. One is cardiovascular fitness, different modes of exercise, hyperglycemic control, different ways, and weight reduction, different ways. So we'll stick to hyperglycemia. So the answer is very simple, very acceptable. 150 minutes of exercise, aerobic exercise, would definitely help you reduce the blood sugars and improve the insulin sensitivity. Add to it 2 to 3 times resistant exercise, that would improve the insulin sensitivity. So these 2 are a must and absolutely well accepted parameters. Now I'll be going to few things which have not been known or which have not been highlighted. So I would suggest, number 1, the exercise. In a way, I tell my patients that while you are doing exercise, whatever is the exercise, swimming is the best, cycling second, and walking is third. But whatever exercise you are doing, during the exercise, if someone asks your name, and if you can answer the full statement or a full sentence without little breathing difficulty, then that speed is not acceptable. That is the most practical way of deciding the speed. That's number 1. Number 2, those people who are not having enough time, which is a very common issue these days. Now we are having HIIT, that is high intensity interval training, and we must know it. It is working very well. And what is HIIT? Where generally when we exercise, we have a warm-up period, walk or cycle ourselves with the same speed, and then we have a running down period. But in HIIT, that is high intensity interval training, you work very fast up to the level of about 80% of your target heart rate, very fast for a short period, maybe 4 seconds to 2 minutes, 3 minutes, 4 minutes, then have again a short period of absolute passivity, and then do the exercise again very fast. So this intermittent exercise, multiple papers have now come that HIIT is working very well, probably even better than the regular exercise, and therefore one should give enough attention to those for those people who are not having enough time. That is number two. Number three is the very important thing is the people are doing exercise in the morning and then they are in front of a TV, or more commonly after COVID era, in front of the screen for 8 hours without moving. Just like we are having in front of the screen for last about 1 hour and 15 minutes. Now this is as good as smoking 3 cigarettes within for 75 minutes. So the recent recommendations are very clear. Nothing more than 30 minutes of sitting at a time. So don't spend 8 hours, even though you have worked hard in the morning, enough exercise. But being sedentary for 8 hours or 4 hours consecutively is as bad as smoking, and therefore it is detrimental to whatever you did in the morning. Last thing, if your idea is for weight loss, any exercise, the best of exercise, can reduce your weight at the most by 5%. The recent recommendations are nearly 15%, and therefore caloric restriction is very, very important. Only exercise can improve your glycemia, but it cannot reduce weight or it cannot make you cardiovascular fit. So therefore caloric restriction is equally important as exercise is. So, and the last one is timing of exercise. Again, without any doubt, the morning timings have been considered to be the best, being you are in the circadian rhythm. So that is considered to be the best. And lots of things that we have been doing, our experience says that we have been doing the same thing for years together. But occasionally you go on making mistake and call it your clinical experience. And that is what has been seen in last 4 major trials, which suggest that exercising after meals, of course under medical supervision, exercising after meals helps more to insulin sensitivity, and especially in the later hours of the day, they help. But at present, for those who are listening, clinically, any time of the day, wherever you are regular.
Okay, good. So you really gave a very crisp and a clear message. And then, Dr. Malhar, coming to you, your favorite point. I know that you are like a very strong proponent of muscle building. So how do you suggest your patients about muscle building? Because we know that the muscle mass determines the insulin sensitivity. So
Yeah, that's true. So finally, I find Indians very defensive when it comes to weight. They will keep saying my weight is normal, but they don't understand that for every year after the age of 25, you lose 1% of muscle. You retain your weight, but it's replaced by fat because you haven't done any resistance work. By the time you're 55 and you've just developed a slightly higher A1C, you're already 25% muscle mass lower. Now you go and starve yourself even more and lose another 5% of muscle mass in your 15% weight loss. So we become sarcopenic so quickly, and then the drug dosages have to compensate for the lack of muscle, because finally, where is the sugar going to go? So I find that very quickly by the 2nd or 3rd month after the calorie restriction phase, a person must start structured, progressive weight training, which is not necessarily radically high levels of weight with very low, repetitions. It can stay in the 10 to 15 repetition range, age appropriate, as long as they do it frequently enough. So the exercise has a principle called FITT, which is frequency, intensity, time, and type. As long as the frequency is good enough, like Sir said, 2 to 3 times a week, intensity is reasonable, the protein intake compensates, you have sufficient duration. You don't just do lip service to it. You do a good 30 minutes, 40 minutes of weight training. And that type of training has to be proper structured weight lifting, which is not heavy weight lifting. It's just just like even if you lift a 5 to 7.5 kg dumbbell, and what my preferred way of prescribing a weight training to a patient is the volume that he has lifted in that particular session. Instead of calculating how many reps, this, that, he just multiplies the total weight. So if he lifts a 10 kg dumbbell 10 times, he has done a 100 kg lift. He lifts 3 sets, it's 300 kgs. And he does 10 such exercises in one gym session. He has quantitatively lifted 3,000 kgs of weight. So the volume is very easy to calculate for upper body and lower body. So that's what we tell them. Just get 2 to 3,000 kgs of lifting in a sensible rep range. And don't go too much body weight, because body weight, they keep doing squats and push-ups and jors. And as it is, diabetics have fragile shoulders and fragile knees. They develop frozen shoulders so quickly because they do 50 push-ups, 60 push-ups, in the urge to burn sugar. So I tell them, don't do that. Just do a lightweight training structured in a gym. And I find magical results in 3 to 6 months with the A1C. Because my belief is while diet will reverse diabetes, exercise will sustain the reversal. Okay, because diets are inherently unsustainable. In our ecosystem, beyond 6 months, you can't live like a monk. You are going to go out to restaurants, to weddings, festival seasons. So I think exercise has to become omnipresent, at least 3-4 times a week, all 52 weeks. That's my pet topic, so I can go on, but I'll stop.
Okay,
We'll
thank you.
separate session on
So
that.
I'm very happy that all of you recommended that it's not only the diet, but over and above that, the stress management, aerobic exercise, and the strengthening or the weight training, they also play a very important role in management of a diabetic patient. So with that, I would like to thank all of you for your time and sharing your wisdom, experience with our audience. And I'm sure that we will have more webinar, similar type of webinar on these healthy lifestyle topics. And with that, I wish everyone a good luck and good health. Thank you.
Thank you.
Thank you.
On behalf of all of us, thanks OrthoTV and thanks Dr. Dhiren bhai. Thank you very much.
Thank
Thank you.
you.
Thank you,
Yeah,
sir.
bye.